Good morning, everyone. Whether it's time allotted or allocated, we'll try to complete this discussion this morning. So I'm going to talk to you about fresh frozen plasma and some of the myths around fresh frozen plasma and some of the reality that, again, I'll present to you. So I broke up the discussion this morning into topics, if you will. The first one is actually what is the plasma that you use and the different populations of plasma out there. So again, the true legal term, if you will, for, and I mentioned this before, for these blood products is actually components. Some of you may remember that in 1990, the Congress decided to make blood no longer a product, it's now a service, and now is to cover the issue of product liability for those who manage to produce these components and sell them to us. Then I'll talk about the conventional approach to testing and where the limitations are and what some of the future and hopefully some of the present that we'll see here at Englewood Hospital. The issue, of course, of where does fresh plasma or fresh frozen plasma become effective, and then look at some patient populations, if you will. The first one, of course, is the trauma patient, where now there's a big move, if you will, across the nation to increase the ratio of plasma to red cells, including, by the way, platelets. And there's a whole controversy around this area because there is very little evidence, if you will, but yet the amount of popularity as well as the conversion of this practice is putting an enormous burden on the supply, if you will. And last is talk a little bit about the limitations of plasma as well as the competing strategies, meaning other products that are out there which may be more effective. And the reason I bring that to you is because in Germany, for example, you cannot get fresh frozen plasma anymore. Everything is goal-directed therapy with components and concentrates, which include fibrinogen concentrates as well as clotting factors. So there are countries where plasma has taken the back seat or has completely been removed from the armamentarium. So let's talk a little bit about the component first. So for those of you aware, you know that plasma is usually derived from whole blood, from donor whole blood, but the amount of plasma which is now gone through apheresis is increasing throughout the nation. According to ABB rules, plasma needs to be frozen within 8 hours after collection, but there's now some products which may actually take longer to freeze, as well as some which are no longer frozen. The normal volume of plasma in a plasma bag is between 200 and 250 ml. There's no real quality assurance in terms of the volume, but you really can't exceed 250, and usually they try to stay above the 200 ml. You could store plasma which is frozen up to 1 year and still maintain activity of the clotting factors, although there's some decrement if you in the activity of these. As a whole, you probably can get enough of the clotting factors to behave. The issue, of course, is that when you order a unit of plasma, you generally are convinced that the amount of clotting factors within each unit of plasma is actually normal, and in fact that is not the case. And looking at expiration, the expiration of plasma normally is 24 hours after thawing, although now we have something called 5-day plasma, which allows us to keep the plasma refrigerated for up to 5 days with slightly decrease in factor VIII concentration. Now, you don't need to type in cross for plasma, but you need ABO compatibility. So unfortunately, we need to type specific plasma is considered to be safer than non-type specific. But cross-matching, as you know, is not required because you don't have the ABO antigen as the ones that you have with red cells. So 24-hour plasma, as I mentioned, is the same as fresh frozen plasma. But because we've had a tremendous shortage of plasma in this country, it was decided that now, after collecting it in rural areas, and they couldn't freeze it within 8 hours, we extended it to 24 hours, just giving you the idea of how arbitrary these decisions are. So you can freeze it now within 24 hours if it comes from far away, but in fact, that's when the limit is right now. And I mentioned all the factors are maintained except for factor 8, which declines, but it doesn't decline substantially. But for those patients who are factor 8 dependent, that may be an issue. The reduced plasma, after you take cryoprecipitate from that product, if you will, is a supernate, which again is used for treatment of patients with TTP. You're probably never going to see that in your practice unless you deal with TTP population. Now, with pherese plasma, you can get what's called a jumbo unit of plasma. In a healthy volunteer, which is what we generally like to see, you can pull off about half a liter to almost a liter of plasma and then return the red cells and platelets. So again, we could pull off volume for the patient as plasma or the donor. And again, it will be a single donor, which reduces the risk. And there are newer populations of plasma out there. One of them is pathogen-activated fresh plasma, which is not universal in the United States, still not mandated, but it is in Canada and in Europe. Liquid plasma is plasma that's never been actually frozen, meaning that the donor gives the plasma is then kept cooled for 5 days, and then is used for trauma, generally speaking, or for hemorrhage. The problem with this plasma is that it doesn't go through the normal process, and CMV can actually, because there's no filtration, CMV may actually be a problem. So many hospitals that use liquid plasma actually irradiate this plasma to reduce the transfer of CMV from the donor to the recipient. And there's work now looking at recombinant plasma, which is being done in Japan, and we'll see that probably in the next decade. Now, I'll start off by telling you or showing you one slide that actually addresses the risk, if you will, of plasma. And one of the issues is TRALI, which is transfusion-related acute lung injury. When we spoke about red cells, we discussed this, but as you could see, when you look at the parade of those components that can actually end up with TRALI, fresh frozen plasma is at the forefront. And this risk is actually a pretty high one in terms of the prevalence. It's somewhere between 1 in 2,000 to maybe as low as 1 in 5,000, but it's still very prevalent in terms of risk, if you will, from infusion of plasma with these patients with a high mortality. So unless we can demonstrate that there's a benefit in giving patients plasma, all we're doing really by giving them plasma is exposing them to risk. So now going back to the topic of I'll talk about the coagulation testing and show you again what we've been saddled with over the last century, if you will, in terms of testing for coagulation. And let me start off with the assumption directing this specifically to plasma, that all fresh frozen plasma units contain sufficient product. I think that that's sort of an assumption that many people in this audience have. And that abnormalities of PT and INR, which are used interchangeably, correlate with the risk of bleeding, meaning if the INR is elevated, the risk of bleeding is high in that particular population, and that giving plasma for those patients who have increased INR will correct that abnormality and reduce or eliminate the risk of bleeding. And these assumptions have been propagated and also transmitted from one generation to the other. But when you start taking a look at plasma, you could see that, first of all, the INR, if you will, or the PT, as measured in donated plasma, has a significant variation. So it's not 1.0. The fact that you're getting plasma from the blood bank does not necessarily mean that it's at the 1.0 level. And you could see that about 70% of a plasma that's received from the blood bank actually has an elevated INR. Now, is that significant or not is a whole other issue, but the assumption that you're getting normal INR, meaning with a 1.0, is not, although that's conventional thinking, is not always true. Now, the issue, of course, is if you want to correct the patient who has an INR, say, of 1.3, I could tell you that probably all the plasma in the world is not going to do that. So we have to pick and choose, if you will, in terms of the use of plasma for correction of INR, knowing that these components, again, may have a significant variability. And you don't know which component has the highest INR and which has the lowest INR because we don't measure that. But we have had multiple studies looking at the distribution of concentration of factors in plasma, and you could see again from the whisker diagram here that there's significant variability amongst each of the clotting factors that we're looking for in terms of replenishment in units of plasma. And these studies keep coming out almost every decade to reconfirm the fact that there's tremendous variability in the amount of clotting factors as well as measured INR in units of plasma that are being given. Now, is this a quality issue? No, it's the reality of the biology of these components. Now, the issue, of course, is how do we understand what's happening behind the scenes in terms of clotting? And from Boston, Sonny Zeke has been a big proponent of this, showing again the mechanism, if you will, of clotting and how it relates to INR and how it relates to PT. So let me just walk you through this graph. You could see the INR over here, and then there are lines which represent, to some extent, the PT. INR, as you could see, is not linear, whereas the PT is actually very linear. And you need somewhere between 25 and 30% of your clotting factors to be able to generate a clot that will stop the patient from bleeding. And you could see that at about 30% of the clotting factor, you're already at an INR of 1.7, and you're hovering at 25% at an INR of 2. So with an INR of 2, you can actually get clotting, meaning that the patient's not going to bleed. But we are very tied to the fact that an elevated INR is associated with bleeding. Now, it doesn't necessarily mean that you're going to bleed even if your INR is between 2 and 3, because there are many other components, if you will, to coagulation, which may overcome the reduction of the percentage of clotting factors. So again, keep in mind that there is a relationship, if you will, between the ability to clot, even though the INR is slightly abnormal or prolonged. And here you could see where the 1.3 is. It's clearly very high and does not represent a risk, if you will, of bleeding. But there have been other studies looking at the relationship, if you will, of now the PT or INR and actual bleeding. And what this meta-analysis did is they looked at multiple studies, you can see over here, which are all invasive procedures. And what they looked at is the patients who had abnormal INR, meaning elevated INR, versus those patients who had normal INR. And then what they did is they looked at the amount of bleeding that occurred with each one of these procedures. And at the end of the day, you see that there's absolutely no difference between these patients in terms of elevated versus normal INR. Interestingly, if you actually count the incidence of bleeding, it's higher in the normal INR group than it was in the abnormal INR group, but there was not a significant difference between the two. So again, the conclusion was that the elevated INR, and we're talking about INRs which are as high as 2, there was really no difference between the two groups. And now you understand why, looking at Sonny Zeke's diagram. Now, the big risk is for patients with liver disease, because these patients walk into many hospitals with an elevated PT, and we use INR interchangeably, even though both are very different. And the problem is that we've never really looked at this carefully. What you're doing when you're measuring a PT or an INR is you're measuring only one side of the coagulation system, which is the procoagulant side. You're not looking at the anticoagulant side. The anticoagulant side, as well as the procoagulant side in patients with liver disease, both are lower. And in fact, you could see this as in a normal, healthy individual. There's a balance between the procoagulants and the anticoagulants, and that's what allows you to clot normally. Patients who have liver disease, both sides of this equation are reduced, and there are compensatory mechanisms. So if you're just measuring INR, you will have an elevated INR in that population, but if you measure the concentration of protein S and protein C, they will also be lower. And if they're much lower than the concentration of the procoagulant, patients with elevated INR or have liver disease may actually be procoagulant, or if you will, hypercoagulable, and we see that in liver transplantation. About 25% of patients may actually have thrombosis of their hepatic vein, even though they have elevated INR. And on this slide, you could see how the balance again, is reestablished in patients with liver disease by looking at both sides. So the patients who have platelet dysfunction and reducing platelets count in patients with liver disease, you could see there is compensating factors on the promoting of clotting side or the procoagulant side. When you see reduction of the liver-dependent factors, you could see again that some others which are not liver-dependent increase, but at the same time the protein C and protein S, which are very potent anticoagulants, are also significantly decreased, as well as antithrombin and heparin cofactor 2. So these patients, despite the fact that they have elevated RNR, the risk of bleeding is not the risk that we always perceive, and to really know how much they're at risk will require looking at all of the coagulation. Now, when we're looking at testing, just to show you the conventional test which we do, which is PT-INR and PTT, blood is drawn from a patient on the floor. There is a transport that occurs to the laboratory. The blood then is centrifuged, removing all the cellular factor. Calcium inactivators are added, and the clot initiation is measured in terms of time and light absorption. It takes about 50 minutes after the blood is drawn. But we're looking whether the patient can coagulate their blood, yet the test is being done on plasma, which does not coagulate. So you could see how far removed these numbers are from the reality, if you will, in terms of clotting and assessing the clotting mechanism. Now, there can't be a talk on clotting without showing you this. All of you struggled with this in medical school and probably in residency, trying to remember this extrinsic and intrinsic pathways and the tests that relate to them. This does not exist in nature. This probably was conjured in someone's kitchen in the 1950s, has been republished over and over again, and you had to study this and memorize this for the test, and it evaporated from your mind seconds after you took that test. And in fact, if you look at this, what's missing, now you know that there are many other components of clotting which are completely devoid from this diagram, which include platelets and endothelium, which are extremely active in promotion of clotting. But we still use this. And when we start examining these tests, and this is Ken Mann from University of Vermont, who's done a lot of data generation in terms of thrombin generation. And if you can't generate thrombin, as you know, you can't clot. And again, just to quote this, is 5% of the total thrombin is generated when coagulometer stops. So you're only looking at the tip of the iceberg of the clotting factors. And again, only plasma is analyzed, so you don't see the contribution of other clotting components to this generation of thrombin. And again, you could see that routine plasma coagulation tests, which is what we do every day, reflects 1 to 2% of the entire coagulation process. And here's where you're actually looking, and here's the generation of a clot. Now, I've had the argument that rather than learning the intrinsic and extrinsic pathways, had we learned this table in medical school or in any of the schools that you went to, which gives you the factor name and also gives you the factor half-life, as well as where it's synthesized, whether it's vitamin K dependent or not, probably would make a lot more sense, because when you're replenishing with plasma some of these coagulating factors, you'll know how long those factors would last. Now, where are we moving today from this plasma testing that we're doing into a new realm, if you will, which allows us to look at more of the coagulation system than we've had a vision in the past. And this is looking at whole blood coagulation, which makes a lot more sense. Now, you will get your PT and INR from this, but you'll get a much bigger picture, because now you're looking at all of the components working in concert, even though it's being done in sort of the test tube. And one is the clot strength, which is, again, related to platelet activity, the thrombin generation, which is related to all of your clotting factors or initiation of clotting factors, and again, the stability of the clot, which is the fibrinolytic activity, which occurs immediately after the clot is actually generated. And this is, again, thromboelastography, which is done on whole blood, and can be done fairly rapidly and give you a picture. So we can measure the angle, we can measure the time it takes for the generation of the clot, as well as the dissolution, if you will, of the clot, and then make determinations, if you will, on what components we're going to be using. So directed therapy is, again, cannot be done without the use of proper testing. And by doing directed therapy, we may actually be able to reduce the shotgun approach, which we've had in the past in terms of reversing a coagulopathy. So back to our discussion, the next thing is looking at the effectiveness, if you will, of fresh frozen plasma, and how good is the evidence for fresh frozen plasma. And this occurs almost every decade. Again, everybody looks at the systematic review, if you will, of what's been published over the last few years. And this one is from the British hematologist, but there's another one that just came out early this year that was published in Transfusion. They're all saying about the same, that there's no systematic review specific to the safety and effectiveness of fresh frozen plasma. Most studies on clinical use of plasma are either not randomized controlled trials or enroll small number of patients. And again, making a conclusion based on a small number of patients may not give you the true data. There's no evidence for prophylactic use of fresh frozen plasma, which actually constitute one of the major reasons plasma is used in this country. And there's no adequate risk-benefit analysis already mentioned, but the concern is the dose of plasma, which many clinicians are unaware that the dose actually exists, which is a potential for bias in many of the studies that are done. So I generally ask in a smaller group, not as large as this or a room as large as this, what is the dose of plasma? And I can assure you that most people do not know the answer. But the dose of plasma is actually anywhere from 15 to 30 ml per kilo. So we do have 100 kilogram patients, thinking that you're going to treat them with plasma for whatever underlying condition that they have. 30 ml per kilo gives you about 3 liters of plasma. That's a lot of volume. And by the way, the most common order for plasma is still 2 units of plasma, which is 500 at best, between 4 and 500 ml of plasma. Clearly not sufficient to, again, reverse the coagulopathy if you're going to be using plasma effectively. And many of the studies, again, are not using this dose, this recommended dose, to raise your plasma concentration of clotting factors by 7% per unit of plasma. While all this is going on, in the United States, the use of plasma is going up without any good rationale, whereas other countries in the Western world have contained the use of plasma. And I mentioned in the beginning of the talk that in Germany, there are areas where you can't get plasma at all. Now, similar to red cells, plasma are also not used rationally. You could see this is a study that came out of Canada. They have a few other studies that came out of the United States. Look at the variability of plasma use in critical care and cardiac surgery in Canada. And it's no different in our institution, and it's no different in other institutions in the United States versus Canada or UK. The use of plasma is, again, traditional and cultural rather than scientific in any way. And when you start looking of why physicians order plasma, this is another study from Sunny Zeke in Boston. This is an older study looking at the Mass General, and in the Mass General, 1/3 of plasma is ordered for a number, not the patient's condition, but for an INR. And again, used prophylactically, which there's no data supporting the use of plasma prophylactically. Another study that's just been published looking at where plasma is being used and why it's being used. And you could see again that in this particular study, 44% of plasma is given for non-bleeding patient, meaning for an elevated INR. And by the way, there are other ways of effectively reducing or treating patients' elevated INR other than plasma if you have the time. And these are the 3 areas that you see the prevalence of plasma use. One of them, of course, is in the operating room, and these are all prophylactic uses, the medical ward, and again, high dependency intensive treatment, which is trauma patients in this particular study. Now, when we look at the effectiveness of plasma, this study looked at a small number of patients, so with 12 patients, but the dose of plasma was actually pretty much rational, if you will, or came close to the dose that we just quoted for you. And you could see in this particular group of patients, the pre-RNR is, this is warfarin toxicity, is close to 9. And again, after treatment with plasma, you could see that you're not going to get to an RNR of 1.0, but you have reduced the RNR substantially. The factor concentration, as you see, we talked about 25 to 30%. This is before you've given plasma, and you could see you're still not reaching that percentage, if you will, with the use of 4 units of plasma. Here's factor 7. Factor 9, you're barely approaching 20%. As well as the factor 7, and with factor 10, again, you could see that you may have reached 20%, but you're not in that realm that we talked about in terms of protection. And we're waking up in different areas to suggest that the use of plasma is not rational. This is one publication in Critical Care. This actually came from the Canadian Intensive Care Unit in association with some of the ICUs in the United States, again showing that critically ill patients frequently receive inappropriate plasma transfusion. Many transfusion may be appropriate for the intensive care setting, but again, it's inconsistent with expert recommendation, the old issue that we talked about previously about red cells. Again, another study looking, this was a retro and prospective study of effectiveness of plasma in 100 cases, and now we're talking a large number of patients with liver disease, and again, trying to correct the abnormality. And here you could see that they broke the group down to those patients receiving less than 2 units of plasma, those receiving 2 to 5 units of plasma. Now we're getting into the dose. And the dose effect with 6 or more units of plasma, as you know, clearly is an effective dose. But in fact, you could see under those circumstances with effective dose, the patient's response, if you will, or the correction, is still pretty low, as high as 20% in this particular study. We've known that for quite a while. So understanding that plasma is not effective in many situations, and understanding that the use of plasma is irrational, few hospitals have taken this seriously, and Rhode Island Hospital has been one of them. And what they've done, and published this last year, is did an education session the way you're getting today, then had what's called early enforcement. You would get a call if you were using plasma to actually justify the reason. And then they had what's called active enforcement, where the blood bank would not release plasma if it did not follow guidelines. And I know that that's very hard for people to understand, but in fact, they reduced the use of plasma by 85% without any impact on patient outcomes. So it can be done. It needs some force, but again, understanding that it's not effective and only offering risk under the circumstances, I think help them to achieve this. And there are other hospitals that are doing that. So now we're looking at the issue of use of plasma in trauma, and especially in the United States with the 1-to-1. Now, the 1-to-1 came from the work that's been done in Iraq and Afghanistan. And Brogman was the first to actually introduce this. And what they did is they did a retrospective study on, again, military injury. And you could see here that, again, those who had 1 unit of plasma to 8 units of red cells had a significant mortality, 65%. When you start getting to a higher ratio of 1 unit of plasma to 2.5 units of red cells, you could see it drop down significantly. And here, very, very difficult to argue. As the ratio is even higher, you can get down to about 20% mortality. That is a very, very strong signal in any intervention in healthcare, to be able to reduce mortality this way. But keep in mind, this is retrospective. And one of the problems we have when we do trauma studies is something called survival bias. And you know that it takes time to get plasma. So is it the reason that these individuals died before they were able to get plasma versus those individuals who were stayed alive and were able to receive plasma? And you don't have an answer. You don't have an answer because it's almost impossible to get rid of survival bias when you're doing trauma assessments. Now, John Holcomb and his group looked at some civilian studies, both military and civilian, and here what is represented the different institution, and the size of this bubble, if you will, is the number of patients. And there was matching for their underlying trauma severity score in this population. And statistically, if you see of this 466 injured individuals with trauma coagulopathy, is they're recommending that as the ratio, if you will, approaches 1 to 1, meaning 1 unit of plasma to 1 unit of red cells, that mortality is reduced or survival is increased. But I'm going to use some trick photography, if you will, to show you what happens. If you remove the statistical line, now you're just looking at the bubbles, and tell me what is the difference between this institution and maybe this institution in terms of survival and in terms of the ratio. Well, the ratio here is a lot lower, and the ratio over here is a lot lower, and the increment, if you will, in terms of survival is nil when you actually apply the statistics back into that. So although there is an attempt by the biased people to try to drive this, we do know that there's one thing that's improved survival in trauma coagulation and trauma abnormalities is what's called damage control. And this goes back to World War II and Pearl Harbor, where what the Navy did after these ships were almost demolished by the Japanese Air Force is they drove the ships onto sandbars so that they wouldn't sink. And then they were able to take these, which was for damage control, they were able to pull the ships out, repair them, and put them back into battle. And this is what we do now, is we stop the bleeding in these patients and then resuscitate them. So damage control surgery has been probably one of the biggest advances in patients who are undergoing trauma coagulopathy. When you start looking at the data that's out there and examining, again, this is one systematic review of 35 randomized controlled trials in trauma and hemorrhage, different strategies for using fluids resuscitation. There's no consistency in terms of outcome. You could start seeing how difficult it is to do trauma studies, but yet the conclusions are being acted upon across the country. It doesn't mean that they are wrong, but they've not proven to be right. And many patients are now receiving lots of plasma and platelets without real justification. But just very quickly, showing you that tranexamic acid is now being used also based upon a single study called the CRASH-2 in many trauma centers. So a single study now changes the practice, if you will, in trauma patients. They may be right, but I think we need more data. But when you actually go back to the laboratory and examine ratio and the generation of clot, this high ratio of 1 to 1 does not stand. And actually, a lower ratio has better outcome in terms of laboratory measurement of clot generation. Now, those of you who are always interested in the history of medicine, let me show you how things change in medicine, how we're thinking, even though we may be convinced of something now, that things do change over time. So this is a resuscitator from the 1700s. This is taken from the Great Britain and Ireland Anesthesia History Museum. And you could see here bellows, you could see all sorts of other equipment here. This is the important box because in the 1700s, tobacco, which fills this box, was considered to be a stimulant. And those who actually needed or required resuscitation, tobacco smoke was considered to be a major stimulator under the circumstances. And here's a relief, again, from the Netherlands looking at the attempted resuscitation of a drowned person using modified Dutch method. One resuscitator is assisting respiratory massage in the chest, and the other fumigator is instilling tobacco smoke through the rectum. So this is where the term blowing smoke up your came from. So again, you could see how things change in medicine. And again, this could have been the right thing to do. We don't know, but again, we've abandoned this resuscitating effort. So now let's talk a little bit about the limitation of plasma. And I think that one slide is probably sufficient to show you the limitations of plasma. And I've divided it in terms of advantages and disadvantages. So it's considered the standard of care in the United States. Mind you, It is no longer that in Europe. It allows for partial reversal of coagulation. You're not going to get to an INR of 1. Just abandon that. So anyone who's got an INR of 3 or below, again, if you're going to treat them with plasma, you're wasting plasma, number 1, and 2, putting the patient at risk. And you saw that what happens with an INR of 3. And keep in mind, if the patient is coagulopathic, there are many other things that you need to attend to in terms of looking at the coagulation system. It contains all the coagulation factors required for hemostasis as well as fibrinogen and other plasma proteins. Again, this is the advantage clearly of plasma. And there is some suggestion that thromboembolic disease may be less with plasma than some of the other procoagulants that we use. But the disadvantages is that it requires compatibility testing. I mentioned that already to you. It needs a thawing, although we have now both liquid plasma as well as we have 5-day plasma, which allows you to use thawed plasma right away. There's a variability of continence vitamin K dependent clotting factors. I already showed you that. They're a rare complication, but again, this is a devastating complication to patients, which is transfusion-related acute lung injury, and we've had a few in this institution, and whether the appropriate plasma transfusion, whether plasma transfusion was appropriate, still can be debated. The problem, again, is that we're seeing a lot of patients who are on warfarin who are of advanced age, and in fact, to give the right dose of plasma for these patients requires large volumes, which is another risk, which is TACO, transfusion-associated circulatory overload, which may also have significant consequences for that population. So keep in mind, to really treat them appropriately requires enormous amount of volume, as we mentioned, 15 to 30 ml per kilo. Again, to correct an RNR requires a substantial amount of plasma, as already mentioned to you. Now, you saw Tom Holland. This is different Holland looking at the volume that's required to, again, correct INRs as high as 1.7 as well as 1.3. And our cutoff in our institution for doing invasive procedures in closed space, such as neural space, is 1.5. But again, if you know that you're going to do a procedure, plasma is not the drug you want to use. There are others that you could use effectively. And if you want to replenish fibrinogen, which has now been shown to be correlated with survival and postpartum hemorrhage, you could see that if you're giving plasma to get fibrinogen up, you need 2 to 2.5 liters. If you're using cryoprecipitate, it's about 1/4 liter. But now we also have fibrinogen concentrate, which is off-label use in the United States to raise fibrinogen, but you can actually raise fibrinogen above the normal or what plasma can give you, what cryo can give you. And the parturient, as you know, has a very high fibrinogen level, and where we need to get to supernormal fibrinogen is something that's being debated. But you could see now that you have other ways of dealing with these patients. So last is competing strategies and concentrates, if you will. And we forget them. We zero on plasma as soon as somebody has an elevated PT and INR. But there is a drug out there, which is a forgotten drug called vitamin K. There's cryoprecipitate for those patients who require what's in cryoprecipitate, which may be fibrinogen or factor 13. Prothrombin complex concentrates, which again are being used, as I mentioned to you, in Germany, in or without combination of recombinant factor 7A, which again is an expensive dosing regimen. And of course, there are other concentrates out there, and there are going to be more coming through the industry, if you will, such as fibrinogen and other. There's now recombinant factor 13 too. So I really would like to stress to you vitamin K, because many patients who end up having invasive procedure who receive plasma should have received vitamin K. And vitamin K is very easy because almost every hospital that I know of has vitamin K in their pharmacy. It is a vitamin. And the issue with vitamin K therapy is that even if you give plasma, you still need to give vitamin K. The half-life of plasma is about 4 hours, depending on which of the clotting factor you want to raise. So giving vitamin K, again, starts working very quickly, because if you give it intravenously, it will work within 6 hours. If you give it orally, it would work within 24 hours. There really is no place for these two other modalities, which is IM vitamin K or subcutaneous vitamin K. Now, there's arguments back and forth about the subcutaneous, and I will tell you that it's just not giving vitamin K under the circumstances. There are kinetic studies already showing, but there are people who still like to give vitamin K because of the threat, if you will, of an anaphylactic reaction, which you can get, by the way, from sub-Q injection. But in fact, the way you want it, if you want it to work, it's intravenously and it's also orally. And I showed you that intravenously it works within 6 hours, 24 hours orally. And if you could just plan ahead, you can reduce the use of plasma significantly in these patients going for any procedure. Now, if you need to do an emergency procedure and the patient's INR is around 2, you could still do the procedure and give them plasma if they bleed. There is no recommendation for prophylaxis use of plasma. Now, there are dosing of vitamin K, which are now in both British guidelines as well as US guidelines. And it started off with being 5 milligrams IV, but I think that we're now ending in this country at giving a dose of at least 10 milligrams intravenously. And keep in mind that patients do just very well with that, and that this drug works very quickly, meaning within 6 hours. So if you know someone's going the next day for a procedure, you can give them the vitamin K back. Now, there is this myth in cardiology that patients who are on warfarin, who have atrial fibrillation, after you give them vitamin K, it's very hard to reverse them. But keep in mind, if you're just going to give plasma alone, you should also give concomitantly vitamin K. If you look at all the guidelines, that's what the recommendation is. There is one study that contained 80 patients with atrial fibrillation, of which one patient was difficult to re-anticoagulate after the use of vitamin K. That's where this story comes to cardiology. If you look at all of the data, now those of you, and many in the audience, have tried to anticoagulate patients with warfarin will know it is not an easy drug. So all the patients have difficulty, if you will, reaching the level of an anticoagulation which is therapeutic. And the drug is just, that's the nature of the drug. It's not, has nothing to do so much with the infusion of vitamin K. So the previous indications for the use of plasma is a correction of excessive microvascular bleeding, meaning bleeding and it's not surgical, in the presence of an INR PT, which, as you can see, are greater than 1.5 or greater than 2. Many of the patients you'll examine here are getting plasma with much lower levels. And again, keep in mind they require the dose. Urgent reversal of warfarin. If you have a bleed and the patient comes in and requires immediate reversal of warfarin, now you could use plasma, but as you know, the American College of Chest Physicians recommends the PCC be used immediately because they're low volume and can actually do a pretty good job in terms of reversing warfarin toxicity very rapidly. Correction of known coagulation factor deficiencies for which specific concentrates are unavailable. And heparin resistance, although that's also gone down on the list because there are now antithrombin 3 that can be given separately without having to give plasma. I mentioned already TTP. And fresh frozen plasma in this country is not indicated solely for the augmentation of volume or albumin concentration. But because of the lack of data out there, the American Association of Blood Bank, now they call it ABB, developed a clinical practice guideline or guidelines for the use of fresh frozen plasma. And I can tell you that I was part of this very confused panel at ABB trying to get our arms around something which is very difficult, but because the data out there, as you could see, is not necessarily confusing, but certainly lacking of significant evidence for the use of plasma. So there was a systematic review of the literature. There was a meta-analysis of randomized controlled trial as well as observational studies, benefit and harm of plasma in common clinical scenarios, and we use what's called the grade methodology to come to consensus under the circumstances. This just gives you the flow, and what I'll show you is the current AABB guidelines, which were the latest guidelines for plasma use at this point. And this is just looking at the trauma population, and this is mortality and massive transfusion. And you could see that use of plasma in massive transfusion is actually recommended. And keep in mind, we don't know when, and we don't know how much, and we don't have a ratio. But use of plasma in trauma coagulopathy is appropriate, according to this panel. But when we start looking at other procedures, again, you could see that this is, you're not seeing it here in terms of surgical population and reversal, if you will, of other coagulopathies. Again, you could see that the overall doesn't show any difference. This is for medical patients. And again, this is an acute lung injury. Again, favors not the use of plasma because acute lung injury, as I mentioned to you, has a high association with plasma use. And for multi-organ failure, although it favors, you could see there are only 4 studies, of which many of these are trauma studies. And again, we couldn't make heads or tail, but this is what the meta-analysis showed, that it favored use of plasma in multi-organ failure. But is it a rescue drug under those circumstances? No. And does it contribute to acute lung injury is another question. So the panel had 6 questions in terms of trying to get arms around recommendations for plasma use. And the first one, should plasma transfusion versus no transfusion be used in trauma patients requiring massive transfusion? And here what you see is that the vote was a weak and strong, almost 50%, for the use of plasma in trauma coagulopathy. But when you look at the evidence, you could see that that's very low to moderate strength, if you will, in terms of where the literature is. So plasma is recommended for that particular group. Should a plasma or RBC ratio be used in trauma patients who require massive transfusion? And here you could see that it was a weak and uncertain recommendation, so it's clearly not a strong recommendation, and you could see where the strength of the evidence lies, and it's very low to moderate, but mostly low. Next one, should plasma transfusion versus no plasma be used in surgical and trauma patients in the absence of massive bleeding or the need for massive transfusion? And here you could see that the vote was against with some uncertainty, but there was nothing for it. And the level of evidence here, again, is very low to low, but the recommendation was made. Question 4, should plasma transfusion versus no plasma be used for patients anticoagulated related intracranial hemorrhage? And here, again, the sentiment was that there would be a recommendation for treating of plasma, but keep in mind that the current guidelines recommend PCC as first line in this population. And you could see that there's some evidence, which is high strength evidence in this particular population. And the last 2 are, should plasma transfusion be used to reverse anticoagulation in patients without intracranial hemorrhage, meaning the prophylactic use of plasma under the circumstances? And here the vote was against with some uncertain. And again, you could see where the strength of the evidence lies, but I think that most people felt in the absence of benefit, why introduce risk? And your last one is, should plasma transfusion be used in other groups of patients? Which really addresses the prophylactic use of plasma. And you could see here that there was a strong sentiment against the use of prophylactic plasma. With uncertainty, there was not a single vote for the use of prophylactic plasma. But as you could see, the evidence still remains in terms of strength between low and very low. So this basically gives you your updated recommendation for plasma guidelines. Keep in mind that there are other modalities that we could use for these patients, but understanding the clotting mechanism, if you will, and understanding that we're only looking at the tip of the iceberg when we do our tests, and we need to have better tests to be able to assess the function of clotting in an individual patient. And just reaching for therapy or intervention based upon a number is probably not the right thing to do. And I think that sentiment is not just shared here by myself, I could declare my bias, but also by other institutions. And if you recall, the Rhode Island hospital activity shows that you can reduce the use of plasma significantly, yet still use it 15% of the times appropriately, and reduce the risk, if you will, to patients who are exposed to that. So those of you who want to hear more about this, the Society for the Advancement of Blood Management, advertised here, urge you to join. But also they have their meeting this year, the annual meeting in the great town of Pittsburgh, from what I understand, is a sleeper. But the information that you get, I think, is invaluable. So thank you very much.